Good morning. Good morning. Good. Great. I'm glad you've all had coffee. This is an early start, but I think we have a very important topic to discuss, and I'm delighted to be able to chair this session that has four really excellent speakers who've been very closely involved in developing a response to the crisis in Europe, to the economic crisis and in its effects on health. We have with me my co-chair Hans Kluge. Hans is director of global health, director of the Division of Health Systems at the World Health Organization European Regional Office in Copenhagen. Then Laura McGarrigle, who is the principal officer at the Universal Health Insurance Unit in the Department of Health of Ireland, and Farhad Riahi, who is head of healthcare systems at Novartis, and to the extreme left, not necessarily his political position, but is my colleague Helmut Brandt, who is the Jean Monnet Professor of European Public Health. He's also head of the Department of International Health at Maastricht University, and recently authored a paper that was published in the BMJ looking at the economic impact of the health effects of economic crisis in Europe. What we have in terms of economic crisis is something that is quite unprecedented in terms of the length of the crisis and the depth of the crisis affecting Europe. Not since the Great Depression of the 1930s have we had such massive declines in growth of the gross domestic product, and this is affecting particularly the vulnerable populations. It's quite amazing. In my country, in the UK, we have people who have got to reduce food intake because they cannot afford heating. And only last week, one of the energy companies increased their prices by 10%, to the horror of everyone in the country. We have food banks. So many people actually attending these. I mean, this is Europe, one of the richest regions of the world, and this is in one of the richest countries in the world. So the effect is far beyond the numbers that we've been able to capture in a few papers that have been published in journals. It's really hitting many, many people, families, and affecting the fabric of the society. And health, among other areas, is one of the areas most affected. Yet, I think this is also an opportunity. So we've had many papers saying that this is a big, big problem, economic crisis affecting health, but some countries have used this as an opportunity to introduce some changes and reforms that were far needed to better prepare individual countries, but also Europe to develop more resilient health systems to respond to future crises. I'm sure there will be many, given that the regulatory frameworks have not been put in place to prevent another economic crisis or financial crisis that will be followed by an economic crisis. So with that optimistic note, I'd like to invite my colleague Hans Kluge. Hans has recently led on a major study looking at the adverse impact of health and the responses in European member states to the economic crisis. So he'll share with us some of the findings, including the deliberations of the meeting that was held in Oslo, which I gather was very successful. Hans, the floor is yours.
I mean, there's a lot of challenges, but a lot of work has been done as well, and I hope that some of the presentation will be able to transmit that. I like always to start with the major health challenges from a WHO point of view. WHO meaning the Secretariat with its 53 member states, because our European region covers 53 countries, and by far the biggest challenge we see is the inequity. Here you see a graph with the life expectancy at birth by different sub-regions. The top line, here you see a little bit the laser, the top line, the dark orange, is the life expectancy, which is the highest among the region of what we call the EU 15 countries, the 15 countries which joined first the European Union, followed by the lightish orange color, which is the average in the European region, again meaning 53 member states, and then lower, the bluish one, the third one, is the EU 12 countries, the EU countries joining after May 2004, and then below you see the countries, the average of the Commonwealth of the CIS countries. And what you see at once is the huge inequity between countries and sub-regions, but if you would delve into each specific country context, you would see, in fact, the same, also the inequities within the country. For this, the WHO developed with its member states a European health policy, Health 2020, which is a kind of a coherent policy framework to give guidance to the countries on how to tackle the main health challenges. It has two strategic objectives. The first is improving health for all and reducing health inequalities. And the second is improving leadership and participatory governance for health, with 4 priority areas. A life course approach, then to tackle the burden of disease, which in our region is a double burden. Like globally, the biggest burden is non-communicable diseases, but still in many countries we face a huge challenge of, for example, multi-drug resistant tuberculosis. Unfortunately, we're also the only region in the world where HIV is still on the rise as well. The third pillar of the policy is health systems, and then the fourth is to build resilient communities. And that's the kind of the chapeau under which we are working. Coming then to the topic of my speech, since the onset of the crisis, WHO has been trying to assist its member states quite intensively and also to generate a robust evidence base. And these are the cover pages of a number of documents which are on the website addressing the financial sustainability in health systems, a first survey among the 53 countries on the health policy responses to the financial crisis in Europe, then an excellent work thanks to the political commitment in Ireland, where Laura, I'm sure, will say something more. It's the health system responses to financial pressures in Ireland. We worked on together. The Health 2020, a lot of evidence which is culminating now into 2 volumes, which we will launch at the Health System Conference 19 and 20 November in Vilnius, in Lithuania, which currently has the EU presidency. The first volume is Health Systems and the Economic Crisis in Europe, Impact and Policy Implications. And based on that one, there is a second one, which is about country experiences. They're delving more into detail in a number of countries. And this is thanks to the excellent collaboration with the WHO European Observatory on Health Systems and Policies. In a nutshell, without going into too detail, there is strong evidence that negative health effects arise during the financial crisis and the economic recession, particularly and worrying for the poor and the vulnerable. In terms of morbidity, this is most obvious looking at the rates of suicide, where we see in the European Union, here the graph, that from 2007, the downward trend in suicides, both in the EU 12 and EU 15 countries, has unfortunately reversed, and there is an upwards trend. Knowing that suicide is only the top of the iceberg, so underlying is a lot of increasing morbidity of mental health in the times of the economic crisis. And we know that the single most powerful determinant whether you fall ill in times of crisis is long-term unemployment. And not only long-term unemployment, but even the fear that people might have to become unemployed. So hence, really the necessity to look further than the health determinants per se. As I was telling, we are also now doing a lot of hands-on country technical assistance. At the top is a picture of our regional director who signed the agreement with the Minister of Health of Greece and the head of the EU task force, Mr. Horst Reichenbach, where we are now assisting in a huge reform package in Greece, where we find a lot of leadership and political commitment that the Minister of Health is taking forward. Recently, we went to Cyprus, the Minister of Health of Cyprus there, which is a different story, because in Greece we see that it is possible to cut a lot what we call fat, basically waste, right? You first have to cut the waste in your system. We know from our surveys that each health system in the region, and frankly speaking globally, has between 10 and 25% of waste. So the first thing you would do if you have to cut is to cut the inefficiencies. In Cyprus, this is not the story, because the health spending is the lowest in the OECD countries, only about 3.8% of the GDP. So there is no fat to cut, and you cut immediately into the bone. So that are the huge challenges that the Minister of Health really have to tackle. And this basically has to be done by not only a crisis management, but looking at some structural inefficiencies which are underpinning the health system, which should have been tackled whether there is a crisis or not. And then we have our good colleague, the Minister of Health, Mr. James Riley, in Ireland, where we also, thanks to the excellent collaboration, including with Laura, are collaborating very well and learning a lot of lessons for the other countries in the region. Based on all this work, we organized a high-level meeting in Oslo, as Rifat was telling, 17 and 18 April, with the 53 member states and the multilateral organizations like the IMF, the World Bank, the Troika, to put the evidence on the table, and we came up with 10 WHO policy lessons and recommendations. And this meeting was generously hosted by the Norwegian Directorate of Health. These policy lessons and recommendations were then presented at the regional committee 3 weeks ago in Turkey. This is our annual board meeting with the 53 ministers of health and unanimously endorsed. I will swiftly go through all 10 without dwelling on them, obviously. Number one is the reforms and measures during the crisis ought to be consistent with long-term health system goals. So it's not enough to look at acute crisis management, but you have, as Rifat was telling, take advantage to try to tackle some structural challenges. These are, for example, the move towards universal health coverage, have a more focus of your health system around the primary health care, with a lot of focus to public health, meaning disease prevention and health promotion, to avoid, in fact, that people develop early on in stage comorbidities and events which can be avoided. The second lesson is factor health impact into fiscal policy, that fiscal policy should take into account the negative impact of the crisis on health and health systems. A major outcome of our high-level meeting in Oslo was that now we have a dialogue with the non-health actors, which basically are dictating in a lot of countries the health systems. Because what you see during the impact of the crisis is that the portfolio of health moved in a number of countries de facto to the Minister of Finance or even the cabinets of the prime ministers. So in that sense, this dialogue is very important. The third one is that safety nets can mitigate many negative health effects. What does it mean? It means that even within a restricted budget envelope, the government and the ministers do have a choice where to allocate funding. So it's true that it's a tough situation, but even in the tough situation, like Laura will demonstrate, if there is a political commitment, like there was in Ireland and some other countries, it's possible to allocate funds to protect the poor and the vulnerable, to protect equity, and to invest in areas which stimulate economic growth. The fourth one is to target efficiency gains over patient charges. By all price, we should try to avoid putting the burden even more on the patients, particularly the vulnerable, and first and foremost work on the inefficiencies. It means not to have cuts across the board, but what we call cut wisely. And of course, it's very difficult, because we see this when working with the Minister of Health. Sometimes they have to sit around the table, they have the troika, and by tomorrow morning or the next days, they have to make very tough decisions to present to the Prime Minister on where cuts can be made and what has to be protected. And obviously, the most easy is, for example, to introduce co-payments. But we know that co-payments and patient charges are in fact what we call the sledgehammer of fiscal policy, because this cuts the services, it's true, but indifferentiately. It means it will cut both the necessary and the unnecessary services. Point number 5, that Professor Helmut Brandt for sure will also touch upon, is to protect funding for cost-effective public health services. Shamefully, if you look across the EU countries, only 3% of the health budget is dedicated, according to OECD, to public health, meaning the prevention, the promotion, the protection of health. Even now, we heard in Gastein, where Professor Helmut Brandt is presiding, a couple of weeks ago, that even the 3% is being cut with really deleterious health outcomes. We see in a number of countries, without naming them, that public health was one of the first programs to be slashed, and what you saw in a short term is, for example, the increase of HIV-infected people, because the preventive programs were being cut. The needle exchange programs were being cut. Policy lesson number 6 is to avoid prolonged and excessive cuts in the health budgets. Again, a very important lesson to convey to the ministries of finance. Except where it is possible to protect access to needed services for the population. Number 7, high-performing health systems may be more resilient. What you see is that there were a number of health systems which were much more resilient to the shock of the crisis. Resilience basically means that a system is able to catch the shock, you reform, but then you come out of it much better. That were the systems which already were doing better before the crisis. They had a good management, they had better evidence to hand to make these very tough policy decisions, and they had an intersectoral mechanism in place to dialogue with the other ministers, including listening to the voice of the people. Policy lesson number 8, structural reforms require time to deliver savings. It means there is a limit how much a country can save and in which time. Again, a very important lesson also to the other ministries and the multilateral partners. Number 9, this is also what we found with the European Observatory. It's very tough to measure the impact of the crisis on health because of our sub-adequate information and monitoring systems. It takes a couple of years before you can demonstrate really the impact, except, for example, on really some sharp indicators like suicide. So this is a huge area for improvement. Number 10, resilient health systems result from good governance. In fact, lesson we learned is that the most cost-effective way to protect health and equity in times of the economic crisis is a continual attention to efficiency, a responsible management of the public resources, combined with prudent fiscal policy. What are the next steps that we see for the region? It's to continuously facilitate dialogue between health and finance. For this, WHO is working very closely with the OECD and the World Bank. With the OECD, we have a senior budget official network, bringing together senior budget officials of health and finance to talk about the finance sustainability of health systems. And the finance ministers are generally interested because health and social sphere is in many countries the biggest, let's say, economic sector. The problem is we speak a different language. Usually the language they speak is, we found out when we met, they have a vocabulary of about 25 expressions, the finance, and it all means no. So if you go to ask for money for health, it's no. So it means we have to up our game as a health professional to really speak a better communication language. To further strengthen policy responses driven by up-to-date evidence, and again, I would like to give a lot of credit to the European Observatory, and to improve the systems to monitor the health impact of the financial and the economic crisis. I'm coming to my last slide. Last week, we had a high-level meeting in Tallinn in Estonia, discussing with the 53 Ministers of Health on the future health system directions. And obviously, we also came out with a lot of recommendations on the impact of the crisis. A key one was that if we're going to do better and more in health systems, it's not going to do the trick. Basically, we have to speak about transformation of health systems. And this will take time, and it has to be people-centered. And lastly, 6 and 7 November, I'm inviting you also on behalf of the Kazakh government. In Almaty, we will commemorate the 35th anniversary of the Alma-Ata Declaration on Primary Healthcare, for which, with Professor Rifat Atun and his team, we worked on a background paper on the status of primary healthcare in the region and the way forward, which is also what we have to do in the times of the economic crisis. Thank you very much.
Thank you, Hans, for a very comprehensive presentation, really excellent points. And it's really heartening to see how rapidly the WHO regional offices responded, not just bringing together all the member states in the region, but also analyzing what's happening, but also developing responses. Often we analyze and we measure the problems, and with the more analysis to measure the problems more precisely, and further analysis to get more precision. But I think the effort here is actually to develop responses. I think we have time for some questions for clarification, but also directly related to the subject that Hans presented. So if you have any questions, please raise your hand. Not enough coffee yet. No questions? Okay. Well, maybe in that case, we'll move to Lara's presentation. Lara will present on the response in Ireland. Ireland had very severe recession following the financial crisis. And they've been able to come out of the recession actually fairly well. But the recession was used as an opportunity to introduce some structural reforms. So Lara is going to share with us the success stories from Ireland. Thank you.
Thank you very much, and hello everyone. Firstly, thank you very much to the summit organisers for the kind invitation to speak at today's event and to share with you the experience of Ireland in trying to protect health in times of economic crisis. I'd like to begin my presentation with a few brief words of explanation in relation to the Irish macroeconomic context and our current health system. I'll then focus on the impact of the crisis on the health system and our policy responses to that, and I'll finish up with a very brief glimpse of the road ahead for Ireland. So, as you no doubt all know, in 2008, Ireland experienced a property market collapse, a banking crisis which to date has cost the Irish taxpayer €63 billion. That's equivalent to about 40% of our annual GDP. We also experienced a dramatic increase in unemployment and a collapse in our tax base, both of which precipitated a very sudden and severe fiscal crisis for the Irish government. And the effect of all of that combined was really a dramatic increase in our national debt levels from just 25% of GDP in 2007 to 108% of GDP in 2011, as the Irish sovereign took on very substantial banking debt as well as trying to deal with a budget deficit. So what was the impact of all of that for the health system? Well, just before I describe the consequences, it's necessary to very briefly describe our health system. So Ireland has a national public health system funded by general taxation, where services are financed, organised and delivered by a single national entity, the Health Service Executive. Under the system, every member of the population is covered for hospital care, but notwithstanding that, 45% of our population have chosen to buy voluntary private health insurance, predominantly for the purpose of purchasing faster access to hospital care. So, before we even go on to speak about the economic crisis and its impact, we can see that the Irish health system faces some internal challenges, namely the fact that the Irish population themselves find public hospital times simply unacceptable, and that has resulted in an unfair two-tier system where people will buy faster access to care. We also have fragmented coverage for primary care services, and that has resulted in a model that's too hospital-centric. In addition to all of those internal challenges, we also have been confronted in recent years with very, very significant external challenges brought about by major fiscal retrenchment. And quite simply, what that has meant is that public spending between 2009 and 2013 has been cut by 12%. As well as the absolute reduction in expenditure, public spending on health has also reduced as a share of total spending on health in Ireland. And that is very notable when you consider that it's happening against a backdrop of reduced ability to pay for health privately in our Irish population, with many people having no choice but to drop their private health insurance cover. So all of that combined means that, not surprisingly, we've seen overall health spending per capita in Ireland fall by 8% between 2009 and 2010. That was the largest fall of any EU member state and well above the EU average of 0.6%. That contraction in public spending also happened against the backdrop of increasing demand arising from a various array of factors. First of all, in Ireland, we've actually had very significant population growth, as you can see. We have also had population ageing and a rising incidence in chronic disease, and somewhat uniquely to Ireland, we've had a baby boom, which, as you may have noticed, I'm about to contribute to the statistics in that regard shortly. And then finally, we've had an increased number of people qualifying for means-tested health services and supports because of rising unemployment and declining private incomes. So, we have a situation of rapidly decreasing resources and increasing demand, but that's still not the full picture in relation to the Irish health system. And that's because the Irish government is committed to the most fundamental reform of the health service since the foundation of the state. The ultimate aim of the reform is to have a fairer, more efficient, more effective single-tier health system where there's universal coverage for the whole population to primary and hospital care, and where there is equal access based on need. So a very important, very, very ambitious reform programme. But what all of that means, of course, is that in framing our policy response to the crisis, we're actually dealing with a trio of challenges, with the triple threat, if you like, of reduced funding, increased demand, and the very, very important but tricky task of not just maintaining service coverage, but actually trying to expand it. And all of that leads you to the inevitable conclusion that we have to focus on actually improving the performance of our health system, and indeed, to steal a phrase from Hans, transforming our health system. Our minister maybe puts it a little more simply. He says, don't cut services, cut the cost of services. And really that's very much been the overriding principle that we've adopted in our policy responses to the crisis in Ireland. So some of the most significant and most immediate responses to our health crisis have involved, firstly, various initiatives to reduce pharmaceutical costs. For example, we've recently brought through legislation to enable generic substitution and reference pricing. But also, very importantly, we've concluded a number of major agreements with the pharmaceutical sector over the last number of years, which on the one hand have led to very significant cost savings for the public system, but at the same time they've allowed for space for new and innovative products to come on stream and actually be covered by the Irish health system and be available to people through the system. Secondly, we've reduced payment rates to contractors such as GPs and dentists. We've also reduced public sector pay rates, but very importantly, in addition to that, the Irish government entered into national wage agreements with the public sector union, which in return for some certainty over pay rates, etc., have delivered really significant industrial peace and have also allowed for redeployment of staff across the public health service and for the development of new service models and new skill mix. And I think it's important to emphasise the contribution of a flexible workforce to framing an effective response to the economic crisis. Really, the Irish health workforce has demonstrated an exceptional ability to embrace change and to do more with less over a very sustained period of time in very, very difficult circumstances, and often with a lot of negative media criticism about the public health service, which can be hard for those working at the front line. All of that said, and critical as all of those immediate responses were and are to managing the crisis, of course it's widely acknowledged that widespread, systematic and structural change is needed, particularly in order to address those internal challenges I mentioned at the outset. And indeed, we have a major portfolio of initiatives that are ongoing in that regard under the umbrella of our health reform programme. I'll just mention a very few of these. Naturally, they're all mutually reinforcing, pieces of a jigsaw puzzle, if you like. But first of all, earlier this year, the Irish government launched a whole-of-government health and well-being strategy, a major strategy called Healthy Ireland, or HI, as we like to call it. And that's really about tackling the underlying causes of ill health and disease in Ireland. And very importantly, it was launched by our Prime Minister and by the whole of government to send a message of health in all policies. Aligned very well with that, in terms of early intervention and prevention, is the recent budget announcement by our government to extend universal GP care to every child in our country aged 5 and under. That's as a first step to having universal coverage for every member of the population for primary care free of charge at the point of use. Moving from primary care to hospital care, we're currently in the midst of a massive reorganisation of our 51 acute public hospitals down into 6 major hospital groups. That work is well advanced at the moment in terms of having 2 groups already quite well established out of the 6. Of course, it's about enhancing efficiency and economies of scale, but very importantly, it is also about quality through appropriate specialisation of services. And then that structural change will be underpinned by new financial incentives. In February of this year, we published a new Money Follows the Patient funding policy, which has been very well received during its consultation phase and which will go live from January 2014 onwards. Obviously, when you think about funding, you must match that with appropriate quality standards. And so we've also published new national healthcare quality standards, which are in the process at the moment of being underpinned by a legislative framework. So that's just a flavour of some of the big structural change that we're trying to drive through at this period of time, at this period of crisis. However, as Hans has alluded to, no one doubts that structural change is difficult and it takes time and it doesn't deliver savings overnight. And so there's no doubt that we're not out of the woods yet, that many challenges do still lie ahead of us, including the very immediate challenge of having to achieve a 361 million decrease in our public spending in 2014, which is a significant challenge. In facing that challenge, our aim will be, as ever, to try and ensure that short-term cost-saving measures are not inconsistent with our long-term health policy goals and not inconsistent with our health reform programme, which aims to improve the health of our population, to provide universal coverage of our population, and to drive efficiency. And so, of course, the importance of evidence-based policy-making will be paramount, and to that end, I must acknowledge the excellent work and assistance that's been provided by the WHO and the European Observatory on Health Systems and Policies, both their general overall work and their very specific work where they came to Ireland and engaged in a very fruitful policy dialogue that resulted in the excellent report that Hans has mentioned, but also in a very real way in a very positive budgetary process for Ireland in that year, where we were able to bring a lot of evidence to bear on the question of how to manage the health budget coming into this current year, 2013, and we're able to frame a very positive dialogue with our counterparts in the Ministry of Finance. So, a real-life example of the evidence and the research influencing hard policy choices in a very real sense. So that was a whistle-stop tour of the experience of one very small, very rainy island in trying to protect health in times of economic crisis. I hope you found it interesting. There's some further reading there if you want to know more, including the World Health Organization report on our responses to the crisis. So thank you very much.
Thank you, Laura, for a really excellent presentation. Clearly, Ireland has been resilient in terms of being able to cope with the crisis, but also being able to respond very decisively. Before we have questions from the audience, I have one question to you. Introducing structural reforms are very difficult, especially in times of crisis. Who led the process?
In terms of the structural reforms, there was a very, very clear vision from our government at the outset, an absolute commitment set out in our programme for government that we were going to reform, we were going to change. And our minister has very much led on those reforms, going personally around the country, for just to take one example perhaps of the hospital groups, because that's quite dramatic and probably quite relevant to people, this idea of actually trying to rationalise public services from 51 acute public hospitals, reorganising those into 6 groups. He went around the country personally, meeting with everybody in the hospital sector, listening to concerns and setting out a very clear vision. He was supported by an excellent team who led 90 face-to-face meetings across the country. Aligned with that at a whole of government level, I mentioned the national wage and partnership agreements. So that's the government itself has taken a very hands-on approach to working with the public sector to try and ensure not just industrial peace to allow you to maintain services in times of crisis, but actually to allow transformation of services. And it has, I mean, when I go abroad, one of the things I regularly get is this sense of how have you managed to have such a willingness to change in the time of crisis. So I think that that's been very important in driving through structural change as well.
Because I mean, those of you will remember in the breakup of after the breakup of the Soviet Union, many countries faced really extreme crises. But it's been very difficult to rationalize the hospital sector. So I think Ireland stands out as one of the few examples where this has been achieved very rapidly. So many lessons to be learned. Any questions from the audience? Yes, we have 2 questions. Please introduce yourself and present your question. We can't hear you, the microphone.
Stefan Balling, I'm a journalist based here in Berlin. I have 2 questions. The first one, would you say that the service now for ordinary people is better than 2007, or is it the same, or is it worse? And the second question is, would you say that maybe the financial crisis was somehow a good shock to start those reforms? Thank you.
Thank you very much. Maybe just to deal with your second question first, because it's the easier of the 2. There's no doubt that, yes, while the economic crisis has been so tough and we're still not out of the woods, it has presented critical opportunities. I don't think we could have made the levels of savings that we made to our underlying cost base and to driving that down in the absence of the crisis. And I also don't think we could have achieved the degree of flexibility in beginning to reorganise our health services in the absence of the crisis. So it was definitely an opportunity as well. In relation to your first question as to whether services have improved or disimproved, there's no doubt that there is pressure on the system. However, overall, we have succeeded, broadly speaking, in maintaining services at a level that they were previously at, despite pulling a lot of money out of the system. We've also, if you look at our hospital sector, is probably a good example of where our hospitals have taken year-on-year budget reductions over, up until last year, there would have had 4 or 5 years of quite significant year-on-year budget reductions, and still over that period of time they managed to increase overall activity. And also last year certainly they managed to reduce waiting times for services as well. The way that they did that was through business process re-engineering. We had a national programme heavily focused on business process re-engineering, and also a significant shift from inpatient to day case and outpatient activity. So it was about redesigning the service to try and actually do an awful lot more with less. Now, of course, we're doing that against a backdrop of ever-increasing demand as well, but nonetheless, we did see activity still continue to increase year on year.
We had a second question. Yes. Would you? Oh, it's been answered. Excellent. Very good. She read your mind, obviously. Okay, we'll move on to Farhad's. Okay, one more question, sir. Okay, well, Farhad is preparing. Yeah, please, pose your question.
Hi, my name is Sabrina Provost. I'm a medical student from Quebec, Canada. And I just wanted to know what was the population response to the changes. And I also was curious about between 2008 and 2013, was it always the same government that was leading this process, or you had elections? Thank you.
Okay, so in terms of the population response to the cuts, obviously, as I mentioned, our public health service wouldn't always get the easiest time in the media. So there has been naturally that challenge that I suppose is probably common across many countries of trying to maintain services while often getting negative media coverage. In particular, people are very fearful of losing means-tested services and supports, so that's a common theme that you would always hear coming through year on year in terms of media or public reaction to difficult decisions. You also asked about the government over the period of 2008 to to the present day. We have had a change of government, yes. Between 2008 and early 2011, we had a government that had to bring through very, very immediate and harsh fiscal adjustment in response to the immediate aftermath of the crisis. Thereafter, a new government, not surprisingly, having brought those difficult cuts through, a new government came into power, a coalition government, and it was the government that in March 2011 set out this very ambitious reform agenda to create a single-tier health system. So it has continued with the programme of fiscal adjustment. And of course, we are a programme country under the Troika. So our national government has been working with the Troika in relation to all of those fiscal decisions.
Thank you, Lara. So we move from Ireland to Portugal, Greece, and Russia. Farhad has been leading some innovative work through a public-private partnership approach to try and introduce innovative delivery models and structuring the health system to respond to the crisis. Farhad. That's another innovation. Yes.
So in a financial crisis, there ought to be two priorities. One is to preserve health, which means to minimize the worsening of health outcomes for patients and for population, particularly for the most vulnerable. And the second is to drive through some reforms that can help make the healthcare system more performant and more sustainable in the future. So what I'm going to argue is that partnerships, generally public-private partnerships in particular, can play a role in helping make both of those things happen better or faster. And I'm going to give you a bunch of examples from work that we've been doing in the healthcare systems group at Novartis and in Novartis more broadly. Not so much as Novartis propaganda, but just because we're doing the work so we know what's actually going on, we can talk about it reasonably authoritatively. So if you start with the first one, which is preserving health. Fact of the matter is that in a major financial crisis, costs have to be cut. There's no question there. The only question is, where is it going to hurt the least? The other thing that's relatively obvious but is worth mentioning is that any healthcare spending is somebody's income. So wherever you cut, somebody is going to complain. That is the nature of the beast. But the people who really ought to be complaining least, or the people we should be trying to help the most, of course, are patients and vulnerable populations. So that should be the focus of this. And as Hans pointed out, a really good place to start is by cutting out things that don't actually add value to patient outcomes or to the performance of the system. So your 10 to 20% of waste. And the good news here is that there's actually quite a lot of information on this. There's a lot of information on clinical activities, diagnostic or therapeutic, that are going on that don't actually contribute to improving patients' health or population's health. We can find these things. So one of the things that at least we found we can do in partnerships is find these opportunities and analyze them perhaps faster or better than any one institution or government could have done by itself, either because collectively as partners we have more data or we just have more analytic capability to sort of get it done more quickly. So we did this in Portugal starting a year and a half ago in a partnership with the Portuguese government, a number of Portuguese academic institutions, and some international academic players as well. And the question on the table was, okay, Portugal is, as per Troika, going to cut costs. Where should it do so? Should it use a sledgehammer or something else? It turns out, if you look across the data published on this, there's a fair amount. So the UK in particular has published a lot, which is relevant to Portugal because of the similarities of the healthcare systems. And you can get quite specific, right? So the NHS has done this analysis for diabetes, looking at self-monitoring of blood glucose. So you sort of take this thing, you sort of prick your finger to see what your blood sugar readings are if you're diabetic. There are pretty clear guidelines on who benefits from more intensive monitoring of their blood glucose. If you then map that against the actual practice in the UK, you find that 66%, or two-thirds pretty much, of these tests are being used by people in whom it's not actually clinically indicated. You do the maths, that's about $250 million. Right? So that's $250 million that you should be able to take out without hurting any patients. Now, clearly the manufacturer of said test is going to complain, but as I said, that is the nature of the beast. The challenge with this, you can find these things, the challenge is then how to actually make them happen. We've looked at the same thing in Greece, and it's a similar story. So if you look at diagnostics in Greece, if you look at MRI scans and CT scans, the latest numbers from OECD, these are from 2009, but they're probably true today. MRI scans in Greece, 98 per 1,000 population per year. So call it 100 per 1,000 people per year. In other words, 1 out of 10 Greeks gets an MRI a year on average. For CT scans, the number is 328. So that's roughly 1 out of 3 Greeks getting a CT scan a year. Right? Just for comparison, the OECD benchmarks are for MRI, Greece 100, OECD 48. CT scans, Greece 328, OECD average 139. The French, who are no slouches at using diagnostics, are a little bit higher than the OECD average. And for the Americans, it's 91 MRI scans compared to 100 for the Greeks, and 220 CTs compared to 320 for the Greeks. Now, my general rule of thumb, and I'll share this with you, you can do with it what you will, on utilization of complex technologies in healthcare is, if you find that you're using more than the Americans, then it's one of two things. Either you've got a fairly special population, or there's something very fishy going on. We can debate which one it is in the Greek case. Right? So the opportunities are there. The next thing that, at least I will argue, partnerships can do is then help to align stakeholders and everyone around the table on actually where these opportunities are and how to capture them. Because it's much easier to say, we are going to defund the following activities. We are going to introduce a copay of 25%. That's a, click, done, and generally speaking, government can monitor it. It's much harder to say, we are going to reduce the inappropriate use of blood glucose testing and actually monitor it and make sure it happens and make sure the cash comes out. Right? I mean, the challenge the finance minister puts to you is, prove to me that you can deliver the cash at the end of the year. Right? And that's a fair challenge. So one of the things that I think we can do better in partnerships, and frankly, we haven't managed to get that far yet, but we're trying, is to then deliver on these opportunities that we can find that we think are better for patients than the more sort of brutal cutting. So that's on preserving health. On driving the right reforms, I'm going to articulate the right reforms maybe a little bit differently from what the other panelists have said thus far. I'm going to make the case that the right reforms are the ones that improve population outcomes for roughly the same cost, or deliver the same outcomes for a better cost. So it's not just the cost part of the equation, it's also the health outcomes, the output of the healthcare system part of the equation that you have to balance. And if you look at that, there's a bunch of things that can be done. For most healthcare systems, non-communicable diseases are going to be the major threat, both to population health and to financial sustainability of the system. You can see this across Europe and most other countries, actually pretty much all over the world now. Right? So one of the questions is, what needs to be in place to actually improve performance on NCDs, which means better prevention, earlier treatment to minimize the long-term and expensive consequences. If you look across the world, there are bits of the universe that have done this. So if you look at Kaiser Permanente in the US, and if you look at hypertension in particular, they've managed to improve blood pressure control rates in their population from 30-something% to just about 80% now. And getting people to blood pressure targets is actually what you need to do to minimize the risk of stroke and heart attacks. Right? Giving people pills isn't enough. They need to actually get to a clinical target. Canada, I'm Canadian because it's, we, quote, have done the same thing. The Canadian Hypertension Education Program in Canada has led blood pressure control rates to go from 15-ish% 10 years ago to well over 60% now, and even higher in some centers. So these examples are out there. Can we apply them more quickly? Can we apply them more effectively around the world? We've been doing a partnership with the province of Yaroslavl in Russia, just north of Moscow, to see if we can learn from this international experience and somehow adapt it to the Russian health system's context. And actually, we've just published the results, I'm happy to say. We've now gone from 17% blood pressure control across Yaroslavl 2 years ago to 23% last year, which we just published. And we've just got the latest data. We're now up at 32%. So, you can do this. And just by the way, for benchmark purposes, if we can get it up to 40% blood pressure control, and you do the modeling around heart disease and stroke, that's going to give you 1 extra year of life expectancy in that population. So it's a fairly significant thing that you can do. Coming back to Greece, so that's something on, can you change the way the system works to improve a major chronic disease? Coming back to Greece, and Laura made this point about a flexible workforce. So we've been looking at the Greek reforms, and so the Greeks have 6 doctors per 1,000 population. The OECD average, just so you know, is 3.2. I can't think of any major country that has more than 4 and change. Of these 6 doctors for 1,000 population, pretty much all of them are specialists. There are very, very few family physicians, primary care doctors in the Greek system. Is that really what Greece needs in the future? Probably not. If you look at the reforms going on in Greece and sort of what's going on with the Troika, is this a major part of the reform agenda? Not that I can see. Right? So one of the things that, we're going to have to do, and again, we're just starting on this one, so we'll see how far we can get with the other stakeholders in Greece, is identify these major issues that really do need to be addressed if you are serious about the long-term performance of the system, and get the right coalition of stakeholders to put them on the agenda, even though it's politically difficult sometimes, and actually figure out what the right answer is. There aren't that many countries that have completely repurposed an oversupply of specialist physicians. But again, there are examples in the UK, what they've done with cardiothoracic surgery and things like that. So again, we can find examples and apply them, but we're going to need to work fairly hard to get there. So what have we learned across all of these experiences? The first thing is, look, we have to be honest. All of this stuff is really, really hard. There are no easy things to do, and the easy things to do tend not to be the right things to do. Right? So we just have to be just honest about that. And they get even harder to do in an environment of political instability. So, we were making fairly, there's good stuff going on in Portugal, and then there were a bunch of, issues of whether or not the government was going to stay in power or not, and things were focusing on that. So, the pace of things goes up and down and changes. Ireland has been, I think, as you said, blessed with having a relatively stable situation that could actually drive things through. The second thing is, I think, we can make the case now that this kind of partnership can add value, whether through finding new opportunities or accelerating solutions that need to be delivered. And most importantly, perhaps, what we're learning about what it takes to deliver that value, I'm going to argue is three things. One is have really multi-partite partnerships, so not just bipolar ones, but the most effective ones we've had are where we've had government, us, other private sector players, academics, all working together. The second is put everything on the table. Find the facts, find the examples, measure the stuff that you can measure, estimate the stuff that you can't, but get the facts on the table. And also get everyone's interests on the table as honestly as possible. And this is tricky, but again, as honestly as possible. One of the observations my more commercial colleagues within Novartis have had is that whenever they've been able to have a conversation with the government around cuts and where they should cut, they've actually been able to come up with a more creative solution that better met both what governments were trying to achieve and what Novartis itself was able to then do in a way that would be in the long-term interest of our operations as well. So we've generally, through talking, been able to find better sort of quote win-win solutions. So put the facts and the interests on the table. And then third and finally, get the international best practice from around the world. And this is where WHO in particular and similar organizations really come into play. There's almost no problem out there in whether it's short-term cost-cutting or long-term reform. There's almost no problem that hasn't at least been looked at or addressed somewhere else in the world from which we can learn from. And most often what we see is countries trying to do things essentially as if the rest of the world hadn't existed. And we can certainly bring more of that to the table. That's it for me. Thank you.
Thank you, Farhad, for these very concrete examples. Yes. Questions? We have opportunity for a couple of questions from the audience before Helmut's presentation. I guess Farhad was very clear. So we'll move on to Helmut's presentation. Was there a question? Sorry. Yes.
Thank you for your fascinating presentation. My name is Nina Edelberger. I'm from the Berlin School of Public Health. I coordinate the Public Health Master's Program. I'm always very interested in the presentations from the pharmaceutical industry in this context because there is such a conflict between, or there's potential for conflict, and I really appreciated the open way in which you presented ways to avoid the conflict between the for-profit sector and the not-for-profit or the government sector. The honesty with which it's important to lay your cards on the table and also your interests on the table was, I guess, very inspiring. What I wanted to ask you is if you can elaborate on one of the projects that you've done. You did stay in the abstract in your presentation, and you showed ways in which there is room for collaboration, but do you have a specific example that you can share with us, or is that too much to ask?
How much time do I have?
Maybe briefly, I think you've had a paper published in Journal of Clinical Hypertension on the Yaroslav experience. Portugal, I'm not sure if it's written up, but
well, I'll probably talk about Russia. So would Russia work? Yes. Yeah. Okay. All right. So the Russia story in a nutshell is cardiovascular mortality is extreme in Russia, as many of you probably know. It's something like 8 times the OECD average, and if you compare it to Canada, it's even worse than that. And so there is a priority for the Russian government to improve cardiovascular mortality. There's also a priority for the Russian government to engage more with multinational life sciences companies and bring some of their expertise into Russia. So in the context of a broader partnership that Novartis has agreed with the Russian government, which includes a number of things, technology transfer, et cetera, one of the things was, can we contribute to improving a major public health situation? And the obvious one to pick was cardiovascular disease. And a particular Russian oblast province put its hand up and said, we'd like to volunteer for this because our problems are worse than the Russian average. So that's how we sort of got into this situation. And again, this is one of those sort of putting everyone's cards on the table and saying, look, what are your interests? What are our interests? There we go. In terms of then what we actually concretely did, we've developed a systematic approach to analyzing the performance of a healthcare system for any particular disease, and then working from there to figure out essentially a 3-step process. What are the outcomes that really matter that we're trying to improve? What are the clinical interventions that drive those outcomes? So if you look in the guidelines, if you look in the literature, what clinical interventions make a difference to improving cardiovascular mortality? And then finally, 3, what needs to change in the healthcare system to make sure those clinical interventions are delivered appropriately? And what everyone looks at when they look at this kind of health system changes, they look at operational changes, process management and things like that. And one of the things that we've learned through doing this work is that it's actually 3 things you need to look at together. There's the operating system, there's the management infrastructure and the performance management system, and there's skills, mindsets, and behaviors, both of patients and of healthcare providers. And so what we do is so any of you who've done sort of lean transformation and those kinds of things, some of this will sound familiar to you, but we then do a fairly rigorous analytic analysis effectively along those dimensions. What are the root causes of underperformance? And you find then real things that you can change. So in Russia, for example, they have the clinical guidelines for how to manage hypertension, but it comes in a book about 300 pages thick. And you're there as a GP sitting in your clinic with this block. This is not helpful, right? So you take that and you turn that into a 10-page, easy-to-read, sort of simple-to-use tool, and then you build a series of medical education programs around that to make sure that stuff's actually in people's heads, right? You see that actually no one knows what the percentage of patients is whose blood pressure is controlled because no one measures that. Okay, fine. So you say, right, we need a measurement system. And then everyone says, arg, we don't have money to invest in major IT solutions. So you say, fine, start with paper and pencil. And guess what? You can get a fair ways with paper and pencil. Well, with Excel spreadsheets. You can get quite far with Excel spreadsheets, right? So you sort of go down that to get into sort of very concrete interventions that you can do at the level of the system. And then you're constantly monitoring to see, look, is this actually making anything change, right? Similarly, on mindsets, one of the things we realized through a lot of interviews with patients is that they don't really get this hypertension thing, right? Okay, I've got this thing, my doctor gives me some pills, I take them from time to time, okay. So the nature of the public health message that goes out then has to change from, hypertension is important to your blood pressure needs to be at 120/80, right? And if it isn't, go back in. And And so that changes the content of a public health campaign that Jaroslav then rolls out. So it's very, very practical things like that. And I'm happy to tell you, in even more gory detail afterwards if you'd like.
But maybe this is a good point to transition to Helmut's presentation. So is this an opportunity for public health?
I hope so. Ladies and gentlemen, you got a very good helicopter overview by Hans about whole Europe, not only European Commission Europe, whole Europe. Then you got a very nice presentation about what a member state of Europe is really doing in times of crisis. And you now got exact examples. What can be done, where, and how it works. So, in a way, I should shut up and we should start the discussion. But there is a little piece in the health system that has not been covered called public health services and public health in general. And in the beginning of the month, we had our European Health Forum in Gastein, and the Greek minister was sitting next to me in the press conference. There is a... Yes. Or can... Yes, let's see. I think, does this work now better? Yeah? And in the press conference, the Greek Minister of Health was sitting next to me, and I was talking about the financial crisis, and then he said, this is not a financial crisis. And so I said, well, what have I said wrongly? Until now, I thought we had a financial crisis. And then he said, this is not a crisis, this is the new reality. So if this is true, that this is now the new reality we have to live for, then shouldn't we change the title of this presentation from opportunities for public health into obligations for public health? Because I think then we really have a different job to do. And I would like to discuss just 3 of those opportunities or obligations for public health. First will be to advocate for health in the political process. The second, to assure that long-term public health interventions are not stopped due to short-term savings. And the third one will be to develop a European identity and develop new ideas for health system reforms. Of course, there's a long list of other issues. I just want to stress those 3. And as we all come from different backgrounds, different countries, I would like to define public health in one sentence: all health-related services outside individual health care and, in some countries, being in charge of the organization of health care delivery, in others overseeing it. And for this job, we spend around 3% of our health budget, nothing more, I guess. First, to advocate for health in the policy process. Our host country here, Germany, has a high-performance health systems that is very resilient to change. And I don't know if you had to seek health services at the moment. It's hard to find any clear-cut examples for crisis in the health system. There's a lot of noise, and there are, of course, some, but here in this country, it seems to work quite well to deal with this. On the other hand, welcome to the town of Robert Koch and Rudolf Virchow. And both were physicians working in public health and realized the social determinants of health. And both saw at that time the political dimension of public health too. Koch even said, looking at the Hamburg cholera epidemic in 1892, I forgot being in Europe. So it's easy for us to understand the situation at those times from looking back from now, but it was not for granted at that times. So public health has to develop a kind of radar system to spot those developments in society that will influence health. And in time of austerity, healthcare and public health are seen just as expenditure, not as an investment. And public health has to prove again and again that the opposite is true. Measures of health keep helping social freedom in a society and to prevent social unrest. In some countries we see 40 to 50% youth unemployment, and that led to some unrest already. Let us not make health the next topic why people go on the streets in those countries. To advocate effectively for health. You have to have good arguments. You know this from your own experience. And that is why monitoring the health effects of the financial crisis is so essential. At the moment, we get our data too late. 3 to 5 years to get mortality data or data about chronic diseases. That does not make sense. When you talk to the Minister of Finance and say, well, you know, now we have the evidence that something went wrong, he will say, well, I'm not the right person to talk to. You should talk to the finance ministers who was in charge 5 years ago. So we really have a problem here. And it does not help the members of parliament either, who have to do the decisions now. Give them the right information. And it does not help the people who manage the system. And so we have to get the necessary cockpit information to steer the system on time. And that we need on regional level, because most in Europe, health management is done on regional level. Sometimes I see those health managers as pilots flying a plane at night without any navigation system. And we really have to bring about change. And when we have the necessary information, we have to secure that good governance takes place. You mentioned it in one of your 10 theses. And good governance, not only in the work of public health service itself, from local to global level, cut out the waste you have here too, but we need good governance in governments as a process of health in all policies. And if you have difficulties to explain someone what health in all policies means, just add good governance to it and take the criteria of this, and then suddenly it's getting very, very clear how good governance and health in all policy can really help to boost society. But most important of all, we have to get political control over our finances and of our economy. As long as we do not have a fiscal union on European level, we will not get the power back, and we will not be able to control our systems. The euro, for example, has been a political decision. It has been a political decision because in this country, some years ago, there was a reunification, and the politicians said we have to introduce this earlier than we did. But it was a political decision, and we lost this political power. And healthcare reforms are politically determined, so we really have to remind this. Second, we have to ensure that long-term public health interventions are not stopped due to short-term servants. We have experience on this. Just remember those countries that had to reform the health systems after the fall of the Iron Curtain. You all worked on this. You all were involved in this. You have the experience. And those countries really had deep recessions and learned some lessons. Let's remember those. What we see at the moment at the effects of the austerity are health effects that are in the area of those environment and health effects. Relative risk of 1.4, 1.2 we see. And just imagine how much money we spend to control environment and health risks. So when we can communicate this in the right setting, there might be a chance that this topic that we are dealing with now, the austerity effects, will be higher on the agenda as they are now. There's an opinion that you can stop public health programs in prevention for some time without seeing any negative effects. We all that it is wrong, but public health has to prove this over and over. The classical example was given by Hans again. The Greeks stopped their social workers program. What they see now is a rise in HIV infections. And public health has to work more on this kind of evidence-informed policy making. And it's our duty to bring the information to the policymaker. This is the same too for primary care. We will celebrate, as we heard, Alma Ata, and somehow this seems to be a town quite far away, and for those very well-developed health systems, we say, well, primary care is not an issue. It is. The European Commission, in their country-specific recommendation, for example, asked Austria to invest much more in this. So primary care is not rolled out in all European countries now. And again, do not waste a crisis. Use it for those reforms even in your own services, that you could not do in good times, because there was such a resistance of power play, of advocates who wanted to keep their own power. Use the times of crisis to do those reforms you already should have done 10 years ago. Let me come to the last point, to develop a European identity and develop new ideas for health systems. Well, we all do have national health systems, but the autonomy in which way health systems operate is more influenced by the European Union. There is one example that is the cross-border directive that we now have, and the story of it is very simple. When you are from a Baltic country and your child has a rare disease, that you will have a center of excellence in one of those Baltic countries is not quite likely because too few population, but there might be one in Spain. So it should be possible that you as a European citizen, and we have this citizenship now for over 20 years, can get treatment for your child in this center in Spain. And the job of the European Commission is to make this administrative possible, that you are not overcharged from the Spanish government because they have to offer some translation services and they have to expand the facilities, and that the Spanish are not overcharged by this, treating more patients from other countries, and that they have to invest more. This seems to be a very good idea, and on the other hand, we see a blocking of the European countries for this because they are in fear losing autonomy. And the European Commission is using this to get all those missing information that they could not get before. For example, information about the quality of services in the member states, about how to integrate a European health technology assessment, or the data should follow the patient. So that means first steps to an internal market in health. There is another issue about European influence that is even more striking. The European Council now has to agree on the budgets of the member states. Before this, they can't be endorsed. And part of those budgets is health. And so Europe has some control about the health budgets now. And they can give this kind of country-specific recommendation that we have seen the last years. And they are very specific. And they are not dealing only with Greece, Portugal, they're dealing with Austria and other countries too. And here we see a growing influence of the European Commission in the management of health systems. So next year there will be European elections, and be prepared. The new Commission will get into health. And I guess in the opening on Sunday, we heard some words from Barroso that stressed this very much. And I'm in an advisory board for investment in health at the European level. And for example, our first job is to think about health systems performance assessment indicators. How can we compare the performance of European health systems? So for public health, a new challenge. And there can be mutual learning from each other in Europe. And that is a task public health still has to learn. We only look at our national system because we say, oh, we can't compare with the others, it's totally different. It's not anymore, because the solutions to our problems are perhaps 5 or 10 different ways, and we see that there is no harmonization of the health systems necessary. They come closer to each other. From Beveridge and Bismarck, we go to Bisurich and Bevermark. Something like this we will see. And on the other hand, there can be European solutions to national problems. Just imagine Eurobonds for the banks and minimal health baskets for Europeans. That Europe defines the minimum standard of a health basket. And if a country can't provide it from a European fund, they are subsidized for a certain time so that this country can pay the bills, even to the pharmaceutical industry, but then later has to pay back or have other solutions for this. So Europe can be a threat, Europe can be a solution, but for public health, it's the most important thing. And I hope that with those 3% we spend for public health, we can influence the other 97% in a way so that we will all see good health in the end. Thanks for listening.
Thank you, Helmut. So Europe a new opportunity or the new threat. I must say, on Sunday, if any of you were at the opening ceremony, President Barroso mentioned health systems so many times. Some of my colleagues from other countries joked with me, said, "Did you actually bribe the president to say all these words?" My work is in health systems. I was delighted to hear him mention health systems, but we were all very surprised. But I think one can see with the European semester and with the new approach, the Commission is going to take a very active role in shaping health systems in Europe. So interesting times ahead. We have about 10 minutes for a few questions. Yes, please introduce yourself.
Marco Hart, Novartis. I think I would be curious to learn from you about your view on differential pricing. I mean, on the one hand, we want to have access to services, to medicines, to therapies for all countries. On the other hand, we have different income levels. There's increasing demand for transparency, and there's decreasing readiness to pay more in the richer countries. Germany is a good example. There is a tradition of paying more over a long time, but it's going down the drain. So what do you think from your overview perspective on differential pricing for therapies and services?
Will be a long process, exactly for the reasons you gave. But would you have thought about 20 years ago that we once have a central agency for our pharmaceuticals, EMA? No one really expected this. Would you have expected that 10 years ago that we have one agency that dealing with infectious disease control on European level, like ECDC? Perhaps. So there will be ways to deal with this. At the moment, I can't give you the one solution how this will happen. Last week, we had a meeting in the European Parliament, and a consultant from PricewaterhouseCoopers gave a presentation about how the future of pharmaceutical industry will be. And there we discussed already the next steps to come. And perhaps what you mentioned will be only a step in between. And I think we will see a lot of different developments in this area. And for example, in this, and there are new ways how Europe deals with this. For example, in this cross-border directive on health threats, there is now the possibility that European countries together will buy vaccines. Something when you talk to national representatives, they would have not agreed on 5 years ago. But for example, there will be a pooling. And for example, this is a very interesting test case because the same arguments you said about different ability to pay, different volume to buy, is true for vaccines too. And for example, that is an interesting case where the first steps perhaps in these directions are made.
Can I ask a follow-up question?
Yes. Are there any other questions? If you could put your hands
Sorry
up.
very much. Maybe okay. I was too abstract. Thank you very much for your answer, nevertheless. But coming back to the example you raised with the Baltic family bringing their child to Spain, let's say the average income in the Baltic states is about 60% of Spain. Means the doctor has a different wage level in Spain than the patient has coming from the Baltics. So staying with this example, what do you think, how would this work in your idea?
The vision is a political one, that this is possible because we have this European citizenship and we have all degrees of freedom in that, for example, the European Court of Justice started to enforce even in healthcare. And if you look at all the decisions of the European Court, it started with the glasses of Decker, it came to ambulatory care, stationary rehabilitation services. And we now have the reimbursement of the money that you would have to spend in your own country. So that's dealt with. But especially I took the example for rare diseases, where we now build up the center of reference. And I imagine that we will have, for the treatment of those patients in 2 to 3 years, a special kind of reimbursement system, because we all benefit from treating rare diseases in centers. And so there is a European added value for this. And I personally can imagine, that there will be compensation mechanisms to make this possible, because the added value we get out of this treatment is much higher than the difference between the wages, for example, that you raised.
I'd just like to add to that, actually. I think the reimbursement systems are completely outdated. They're based on past problems, not the future problems. So I think Europe faces a major danger going forward. It's all hospital-centric, reactive, curative approaches that cater for a small proportion after the events happen. Unless this changes dramatically, then we really invest in prevention and maintaining good health and managing multimorbidity. I think the system is going to come under huge pressure. It's easy to, I think we're measuring things that have been easy to measure over time, but the fundamental way in which we reimburse systems needs to change. Otherwise, Europe has huge risks going forward. We had a question right at the back.
Peter Chang from Yes, I am very impressed by several of the presentation on this. But from Asia, you probably have a financial crisis and health new reality, and so you have a treatment. I mean, the treatment for a better healthcare system. And to me, it looks like the disease is being cured. But many countries in Asia, or including others, they are in a chronic disease. No single treatment can cure this. So I'm very interested to know that how much we can learn from Europeans' experience through this Irish and Portuguese and many others' experience, because that would be a very good example for many other partners in our part of the world. Thank you.
Thank you. I think you've just reinforced what I was trying to say. So what can Asia learn from Europe, or what can Europe learn from Asia? Maybe we'll have comments from each of the panelists, and we'll try and close the meeting. So, Hans.
Thank you. I certainly do not have the answer, but I'm particularly grateful that you raised this matter. I myself, before coming to Europe 4 years ago, I was the WHO representative in Myanmar, in Burma, for 5 years. I mean, in the times that the country was in a different shape. So definitely, in fact, at our high-level meeting on health system strengthening last week, we also invited other regions to learn. And it's true that traditionally, Europe had globally the strongest health systems. But this is also a time for us to be modest and to learn also from Asia. To quote one example is, for example, Thailand. Because from Thailand, we were learning quite a lot on the universal health coverage, and Thailand has been pushing forward also this agenda, including on the health workforce. So I think another element we can learn, in fact, from Asia is the whole community-based approaches. Because I was dealing a lot with TB and HIV/AIDS there, and this is a tremendous challenge in Eastern Europe, where these treatments are very much facility-based. While in Asia you have this history, tradition and culture of really involving the communities, which we will have to do with the aging of our population and the aging of the health workforce. So I think it goes in both ways. And that comes to the globalization that we have, as Farhid was telling, to gather really the international best practices. But thank you for your intervention.
So, Laura.
Perhaps just to speak very briefly about the experience of Ireland in relation to chronic disease management. The government is very committed to completely shifting our model of care away from a reactive hospital-centric one. And while we are, I suppose, in our infancy in trying to do that, nonetheless, one very important initiative that we've embarked on is something called the National Clinical Programmes. These are clinician-led, something which is regarded as extremely important in terms of buy-in and ownership. at the level of healthcare professionals. And basically, they're about re-engineering the models of care so that you have clear defined patient pathways for different types of diabetes patients, for example, that are about giving much better early preventative care in the community. These programs are in their infancy, but they are starting. And linked with that, and just to pick up on your point, our money follows the patient policy that I mentioned in my presentation. Again, it's very early, it's in its infancy, but in setting out the policy, we tried to set out a very clear vision of the fact that we wanted money to follow patients out of hospitals, and we want it to be something that is very much evolving into trying to treat patients over a long period of time, to actually give them better health, to actually tackle chronic disease in a much more holistic way. So that's what we're attempting to do in Ireland, even against a backdrop of reducing budgets. Thank you.
Farhad?
So I think it's as important to learn from sort of negative experience as it is to learn from positive experience. And so essentially, I think the situation is the following. If in Asia, countries go down a pathway of not actually investing in measuring the health outcomes they care about, if they build financial systems that are fundamentally fee-for-service based, and if the delivery models they build are hospital-focused, do not come back in 20 years and complain about the system not working, because you should have seen all of this looking around you in Europe today, right? So I think it's important to just be fairly clear about that. On the other hand, there are within Europe and North America specific examples you can look at where things do work better. So look at Denmark, look at actually most of Scandinavia for the integration of health and social care in terms of taking care of the elderly, for example, and keeping them out of hospital. There are models across Europe of really focusing on a disease and having a disease-based pathway for improving outcomes. And West Germany has a headache center that does that for migraines, for example. So within Europe, there are specific examples that you can look at. And then I think my third point would be, don't be shy about actually standing up for examples of great work that is happening in Asia and elsewhere, and putting those on the global stage as well, because there's a lot going on that actually, if we're honest, is more advanced there than here, because less obstructed by various vested interests and sort of incumbent systems.
Great. Final comments, Helmut.
So, some time ago, we had a visit from a delegation from Asia who spent 2 weeks looking at 28 health systems, the European laboratory. And in the end, we asked, well, what can you learn? And they said, not directly, but very indirectly, nothing, because they all seem to have problems when money gets scarce. And they are not proved for working in a recession. So you really have to be careful what you take out as examples. And Asia at the moment has to be very careful, because you can afford a lot of things and you can afford a lot of inefficiency because you can put more money into the system. The danger is that you repeat the problem, the mistake we did here, just to solve a problem by giving more money into the system, and then it works fine, and then we praise each other that we have a wonderful system. So, for example, Professor Chang, you are representing Taiwan. You just made some years ago a brave health reform that is not well known in Europe, but you looked at all those systems quite carefully, and even American economists praise it, and so that is something where you seems to get the balance right. But the problem will be if, for example, Taiwan would be hit by a recession like in Europe, how would this system behave then? And that is the unknown question. So it's easy to give advice now, but it's hard to predict the future.
Great. I think on this note, I'll try and close this symposium. I will not attempt to sum up, but I think we, as Helmut said, we had a helicopter view from Hans, and we deep dive into a country to see how Ireland was able to respond to the crisis and has come out of it quite well with a great vision. Then we had very concrete examples at operation level from Farhad. And then Helmut brought us back to public health. What are the implications going forward? And I think it's been a really excellent session. And I'd like to ask you to join me in thanking Helmut, Laura, Farhad, and Hans for their contributions.